Okay, welcome everyone to the deep dive.
Hello.
Today we're tackling a really significant and, well, complex topic, bipolar disorder. You might also know it as manic depressive illness.
Exactly. And we're doing this by digging into a specific set of revision notes, really detailed ones.
Yeah, think of this as our plan, our mission, if you like. We're going through these notes together, pulling out the key stuff, the high-yield information, trying to make it clear and hopefully easier to remember for revision,
We're sticking just to what's in these notes, sort of guiding you through the essentials laid out there.
making it accessible, basically.
Huh?
So let's start right at the beginning. How do these notes actually define bipolar disorder? And what about the types they mention?
Okay, so at its core, the notes describe it as a chronic mental health condition, and the defining feature is these extreme mood swings.
Not just feeling a bit up or down then.
No, no, much more than that. We're talking distinct periods of elevated or irritable mood, that's the mania or hypomania part cycling, with periods of major depression.
And the notes mention two main types.
Yes, bipolar I and bipolar II. It's laid out quite clearly.
Okay.
Bipolar, I mean, someone's had at least one full manic episode. They might also have depressive episodes, but the mania is key.
And bipolar II.
That involves hypomanic episodes, which are like less severe episodes of elevated mood, and major depressive episodes.
So the big difference the notes point out is really about how severe that up phase is. Mania versus hypomania.
That's it. Full-blown mania in type 1, the milder hypomania in type 2. It's a crucial distinction for diagnosis and, well, understanding the impact.
Got it. Okay, what about the causes, the etiology? The notes seem pretty clear that it's not simple.
Right. They state up front the exact cause isn't known. It's complex.
Multifactorial, they call it.
Yeah, meaning it's likely a mix of things. Genetic factors definitely play a part, environmental influences, and neurobiological factors, too. Changes in the brain.
And do the notes mention specific biological changes?
They do. They talk about potential changes in brain structure and also imbalances in neurotransmitters, the brain's chemical messengers, serotonin, dopamine, that kind of thing. These are thought to be involved.
Which leads nicely into risk factors. Who's more likely to develop this, according to the notes?
Okay, several things are listed. A big one is family history. If it runs in the family, your risk is higher.
Right.
What else? A personal history of depression or other mental health issues. Substance abuse is mentioned. Stressful life events can sometimes act as triggers. And also childhood trauma or abuse.
Understanding those helps, doesn't it? Not just for doctors, but for anyone, really, to see who might be more vulnerable.
Exactly. It gives context. It's not predictive, but it shows potential susceptibility.
So let's go a bit deeper into how the pathophysiology. How do those biological bits actually lead to symptoms?
Well, building on the causes, the notes point to specific mechanisms. Dysregulation of those key neurotransmitters we mentioned, serotonin, dopamine, norepinephrine, they're all vital for mood.
So if they're out of whack.
Exactly. And also abnormalities in brain circuits, the parts of the brain that handle emotional regulation. It suggests the wiring or chemistry isn't working quite typically.
Right. Rooted in brain function.
That seems to be the idea, leading to those significant mood shifts.
Now, this sounds like it could look like other things. The differential diagnosis section must be important.
Hugely important. The notes really stress this because misdiagnosis is a real risk. The symptoms can overlap so much.
Okay, what kind of things are on this list? It sounds long.
It is pretty comprehensive. You've got other major mental health conditions like major depressive disorder, obviously, schizophrenia, schizoaffective disorder, even cyclothymia, which is like a milder form of mood cycling.
What else?
Generalized anxiety disorder, mood problems caused by substance use or even withdrawal from drugs. Borderline personality disorder is mentioned too because of mood instability.
And it's not just other mental health conditions, is it? The notes mention medical issues.
Absolutely. This is critical. Things like thyroid problems, hyper or hypo, anorexia nervosa, even neurological stuff like a stroke or dementia. Chronic kidney disease is in there too.
Wow. And medications?
Yep. Certain meds can trigger mood symptoms. Steroids are a classic example, isoniazid, L-Dopa, some others, and even physical things in the brain like tumors or infarcts.
Gosh, okay. So that list really shows why you need a proper, thorough workup, doesn't it? You can't just assume based on mood symptoms alone.
Definitely not. You have to rule out all these other potential causes. It needs a full medical perspective.
Let's switch gears slightly. Epidemiology. Who gets it? When does it start? What do the notes say?
The figures given are around 1–2% prevalence in the population. Lifetime prevalence is maybe 2%.
And onset.
Typically late adolescence or early adulthood, that's when it usually first appears.
Does it affect men and women differently?
No, the notes say it affects both genders pretty much equally.
And that genetic link we talked about.
They put a number on it. Relatives have a 5 to 10 times higher risk than the general population. So genetics is definitely a factor.
And comorbidities. Things that often go alongside it.
Anxiety disorders and substance misuse are the main ones highlighted in these notes. Very common.
Right. Okay, now for the really core stuff, for revision, the clinical features, what does it actually look like episode by episode?
Yeah, the notes break this down well. Let's start with manic episodes. This is that period of really high, expansive, or sometimes irritable mood.
Plus the energy.
Yes, a big increase in energy and activity, both physical and mental. Key symptoms listed are things like grandiosity, feeling overly important or powerful.
What else?
Pressure of speech, talking really fast, hard to interrupt, racing thoughts or flight of ideas jumping from topic to topic.
Sounds exhausting.
It can be. Leads to overactivity, starting lots of things but not finishing them. Sleep changes are huge, needing much less sleep but not feeling tired. Easily distracted too.
The notes mention appearance changes.
Yeah, sometimes dressing in bright or unusual clothes, maybe looking a bit unkempt, increased appetite, more interest in sex, maybe becoming disinhibited, and reckless behavior, especially with money, big spending sprees.
And sometimes it gets even more severe. Psychotic symptoms.
Yes, in severe mania that can happen. Grandiose delusions, believing they're famous or have special powers, hearing voices, auditory hallucinations, or feeling persecuted, and often a real lack of insight that anything is wrong.
Okay, so that's mania. How does hypomania compare?
It's basically a milder version according to the notes. You still get the elevated mood, the increased energy and activity, but it's less intense.
And the key difference?
Crucially, without the psychotic symptoms like hallucinations or delusions.
And it doesn't mess up their life quite as much.
Generally, no. Functional ability is relatively unaffected compared to full mania. People might notice they're different, more energetic or talkative, but they can usually still manage daily life. It's a distinct, less severe state.
Got it. And then there are the depressive episodes. These are part of both bipolar I and II, right?
That's right. And they share a lot of features with major depressive disorder or unipolar depression. The notes list the core things. Low mood, much less energy, losing interest or pleasure in things.
What other symptoms?
Sadness, changes in appetite or sleep, could be eating more or less, sleeping more or less, fatigue, trouble concentrating.
The notes add some specific details for bipolar depression.
Yeah, often feeling worse in the mornings. A sense of sadness that feels out of proportion. Appearance might become unkempt, poor eye contact, being tearful, feelings of despair, low self-worth, guilt, hopelessness, they're all prominent.
Physical symptoms, too.
Yes, weight loss or gain, less appetite, waking up very early, loss of libido.
And like mania, can severe depression also have psychotic features?
It can, yes. Things like delusions of being persecuted or believing they're dying, and severe self-neglect, maybe not eating or drinking enough.
The notes also highlight the impact on someone's life generally, their psychosocial functioning.
Which is so important. Bipolar disorder can massively affect relationships, work, social life. The notes really stress asking about this during assessment. It's a huge part of the picture.
And there was an interesting point about binge eating disorder co-occurring.
Yeah, quite specific. A study mentioned found about 18.6% of people with bipolar also had issues with binge eating, higher rates in women. And it seemed linked to more anxiety and emotional reactivity.
Just shows how interconnected everything can be.
Definitely. It needs a holistic view.
Okay, so given all this complexity, how do clinicians actually diagnose it? How do they pin it down?
Well, the notes are clear. The main thing is a really thorough psychiatric evaluation. Getting a detailed history of symptoms, past episodes, current state, that's paramount.
But investigations, like tests, are still important.
Yes, but mainly to rule out other causes, those organic medical conditions we listed earlier that can mimic the symptoms. It's less about diagnosing bipolar with a test, more about excluding other things.
Right. What kind of tests do the notes mention?
Standard blood tests usually. Full blood count, electrolytes, UNEs, thyroid function, calcium. Toxicology screens blood and urine are really important, especially if mania is suspected, to check for substance use.
What else?
Maybe screening for infections, urine tests, chest x-ray, blood cultures, sometimes even a lumbar puncture if meningitis or encephalitis is suspected.
Green scans?
CT or MRI might be done if they suspect a structural issue in the brain, like a tumor or stroke damage.
And ECGs. Heart tracings.
Yeah, routinely done. The notes explain it's because some of the main medications used for bipolar can carry a risk of heart rhythm problems. So it's a baseline check before starting those treatments.
So it's a full medical check as well as the psychiatric assessment.
Absolutely. Then the actual diagnosis, using the ICD-10 criteria mentioned in the notes, generally requires at least 2 significant mood episodes. And crucially, at least one of those has to be manic or hypomanic.
And ICD-10 has subtypes depending on the current episode.
Yeah, like bipolar disorder, current episode hypomanic, or manic, or depressed, or mixed, or in remission. It specifies the current state.
And for mania itself, there's a symptom count.
Yes, the notes mention needing a certain number, usually 3 or more of those specific manic symptoms we talked about, like grandiosity, less sleep, pressured speech, etc., for a diagnosis of a manic episode. Psychosis can be present too.
So the clinical assessment really pulls together the history, current state, suicidal risk, self-neglect, family history, substance use, physical health, the whole picture.
Exactly. And the notes touch on the clinical course too, saying it varies a lot between people, frequency, duration of episodes, symptoms can even fluctuate day to day. But importantly, many people do function normally between episodes.
They define rapid cycling too, don't they?
Yes.
Yeah.
That's having 4 or more mood episodes, manic, hypomanic, or depressive within a 12-month period, with no real stable periods in between. Affects about 10–20% of people, according to the notes.
And that needs specific management focus, presumably?
It does, yeah.
Which brings us neatly to management. How is bipolar disorder treated based on these notes?
It's a combined approach. Medications, pharmacological, and non-pharmacological methods, all tailored to the person.
What are the main medications?
Mood stabilizers are the cornerstone. Lithium is highlighted as the first-line choice, usually. Valproate is mentioned as a key alternative.
And for managing acute episodes, like mania.
Well, first step might be stopping any antidepressant they're on, as that can sometimes fuel mania. Then, atypical antipsychotics are often used for quick control. Olanzapine, haloperidol are mentioned.
What if someone's too unwell to take tablets?
In severe cases, rapid tranquilization might be needed, sometimes under formal Mental Health Act provisions if necessary for safety.
And managing the depression side.
It's tricky. The notes say standard antidepressants might be less effective than in unipolar depression, and you have to be careful they don't trigger a switch into mania or hypomania, so they're used cautiously.
Sounds like talking therapies are important here too.
Very much so, complementing the medication. And the notes also flag managing those physical health comorbidities, the increased risk of diabetes, heart disease, COPD. That's part of the overall management plan.
When should a GP refer someone to specialist mental health services?
The notes suggest a routine referral to the community mental health team, CMHT, if hypomania is suspected. But if it looks like full mania or severe depression, that needs an urgent referral.
Okay, let's talk more about the non-medication side.
Patient education is vital, helping the person understand the illness, its course, their triggers, how to manage it, providing written info, like from NICE in the UK is mentioned.
And psychological therapies?
Yes, things like CBT, cognitive behavioral therapy, IPT, interpersonal therapy, and family therapy can be really beneficial, especially in helping people stay well during remission.
What about more intensive treatments?
ECT, electroconvulsive therapy, is mentioned, but it's usually reserved for very severe cases of mania or depression that haven't responded to other treatments. It's more of a last resort.
And hospital admission?
Sometimes necessary during severe episodes, mainly for safety to prevent harm to themselves or others. Support groups are also listed as helpful. For the long haul, preventing future episodes, the notes mention ongoing treatment with mood stabilizers like lithium or valproate, or sometimes antipsychotics like quetiapine or olanzapine or lamotrigine. Regular monitoring is key, watching symptoms, side effects, triggers.
What about specific groups, like kids or older adults?
Children and adolescents need specialist care. Aripiprazole gets a mention for severe mania in teens. For pregnancy, it's complex, needs careful discussion about risks of meds versus risks of relapse. Some meds might need stopping. In older people, you have to be extra careful about other health problems and medication interactions.
And that rapid cycling pattern. Any specific treatment notes?
The notes suggest maybe combining lithium and valproate as a first-line approach for rapid cycling, or sometimes lithium on its own.
The notes also mention a couple of other treatments that aren't generally recommended.
Right. Topiramate and gabapentin nice doesn't recommend them for bipolar, according to these notes. And transcranial magnetic stimulation also isn't recommended by NICE. ECT is seen as short-term relief for severe cases, not a routine long-term strategy.
So sticking to the established treatments is key. And ongoing monitoring sounds crucial.
Absolutely essential. Regular reviews, especially when starting or changing treatment, monitoring physical health, lipids, glucose, weight, because some meds can affect these, checking for substance use, and always asking about side effects and, critically, any suicidal thoughts.
It really paints a picture of long-term holistic care being necessary.
It really does. It's a commitment.
So given all that, what's the outlook, the prognosis, according to these notes?
Well, the notes are clear. It's a chronic condition. It needs managing long-term.
But there's hope?
Yeah, definitely. They emphasize that with the right treatment and support, people can live full, stable lives.
But prognosis varies.
Yes, quite a bit. Depends on symptom severity, how well treatment works for the individual, and sticking with the treatment plan adherence is key. Recurrence is common, though.
How common? The notes give figures, right?
Yeah, pretty high risk. About 50% relapse within 2 years, maybe 75% within 4 years. It shows you need ongoing management.
On average, how many episodes might someone have?
The notes estimate around 10 episodes in a lifetime, on average. Factors linked to a poor prognosis include having substance abuse issues alongside it, experiencing psychotic symptoms, having more severe or persistent depressive symptoms, especially between the main episodes, and also being male.
Does treatment make a difference to prognosis? Lithium.
Yes. The notes specifically state that long-term lithium treatment improves the prognosis in about half the people who take it and respond well. About 45% tend to have a more chronic course, and generally, the more episodes someone has, the poorer the long-term outlook tends to be.
And the mortality risk.
Yeah.
The notes were quite stark about that.
They were. There's a significantly higher risk of suicidal thoughts and attempts, and increased death rates from physical health problems too, especially cardiovascular disease, like 1.2 to 3 times higher risk.
And suicide risk itself.
Tragically high. The standardized mortality ratio for suicide is given as 14 to 23 times higher than the general population.
Wow. Those figures really hit home. It underlines how serious this condition is and why effective, ongoing care is just so vital.
Absolutely. It's critical.
Which leads us to the final section. Complications. What happens if it's not treated well?
The notes say untreated or poorly managed bipolar leads to really significant problems across the board.
Like what?
Impaired daily functioning, just managing everyday life becomes hard. Major relationship difficulties, higher rates of substance abuse, self-harm behaviors. And reinforcing what we just discussed, that increased risk of suicide and also the impact of those co-occurring medical conditions like heart disease and diabetes getting worse or not being managed well.
Other issues mentioned.
Social problems, difficulty holding down a job, financial troubles, persistent suicidal thoughts. It can really impact every aspect of life.
So the main message here is
regular monitoring, early intervention, and consistent management are absolutely essential to prevent these complications and improve outcomes.
Right. Well, that was quite a journey through those revision notes. We've covered the definition, causes, risks, the biology, the tricky differentials, the epidemiology, the symptoms of mania, hypomania, depression, then diagnosis, management, prognosis, and complications.
It's definitely a complex condition, chronic too, but I think the notes show that while it's challenging, if you have the right understanding, the right management plan for the individual, and that ongoing support, well, navigating it and living a fulfilling life is definitely achievable.
Yeah. And thinking about those high recurrence rates you mentioned and the link with physical health and how vital sticking to treatment is, it makes you wonder, doesn't it? Here's a thought to leave you with. How does everything we've discussed push us to think beyond just treating the episodes towards a truly holistic long-term strategy? One that supports not just mood stability, but physical health, social connections, everything, to really improve people's lives in the long run.
That's a really important question for clinicians, for individuals, for families. A crucial point to consider.
Definitely something to mull over. Keep exploring, keep learning. And if you want to check out the resources mentioned in the source material, have a look at pastthemsra.com and freemsra.com.